And with that, I'm just going to transition our slides and hand it over to the BIOS group for the rest of today's event.
Thank you, and it's very nice to be here. That was a wonderful presentation. Epilepsy, a brain disease, also has a sudden death syndrome. We're appreciative to tell you the story of two great multi-site clinical trials that are going on in the Department of Pediatrics, and at the same time tell you a little bit about BIOS Clinical Trials Center and the support for clinical trials that's available here at Johns Hopkins. These are the presenters and their relationships. And this is a longer list of objectives so that perhaps you'll understand more about what's available to support translational investigators who are interested in performing multi-site clinical trials, the kinds of trials that can change guidelines. BIOS does a number of things to support clinical trials in the translational mode, and we work both with academic people and with industry, although the majority of our work is academic. This is our tree of trials that we've supported over the last 25 years, both in the planning stage and at the clinical coordinating center and data coordinating center level. We really do three things: trial planning, grant organization, and trial operations. And we're going to tell you the story of how we supported the two pediatrics trials. Lou Romer is going to tell us about the kids' MODPA trial, which is a really unique and needed dual therapy for pulmonary hypertension. And we're going to have a tag team, Meredith Atkinson and Gina Miller, who are going to tell us about the RAF trial, which is a fetal trial and is going to probably lead to further trial in both the neonatal and in the fetal stages. And we're going to have comments about how these trials were supported from Lindsay Ezeguer, who supports the kids' MODPA trial, and Nolene Ostrovovich, who supports the RAP trial. So our first speaker is going to be Dr. Louis Romer.
Thanks so much, Dan, and thanks everybody for taking the time to tune in and be here. I want to tell you the short story of an 8-year adventure with the kids' MODPA trial, as has been said, mono versus dual therapy for children with pulmonary hypertension. And as you see from the slide, this is a very much multidisciplinary, multi-member endeavor. And at the heart of the matter are Dan Hanley and BIOS. So as every investigative story, most stories will start with oneself. So one has to ask oneself, with any endeavor of merit, do I really want to do this? Why does this have to be done? And what is the matter that needs addressing? And why me? And then, do I have enough caring about this situation to really navigate the rough spots going forward? And certainly that's a muse we've had to touch base with along the way. So initially, the Pediatric Pulmonary Hypertension Network of North America had that self-examination session, and we decided, the centers that are involved are listed here, to go ahead. And why? Well, we thought we've not done any investigator-initiated trials, only participated in things that were initiated by pharma, and we want to pursue our own goals. And these were they: provide better care for the kids that we care for, learn more about the pathobiology of pulmonary hypertension, which is very complicated and little known, really, disorder of children, pave the way for future trials, and build a PPHNet clinical trials network. And we've come a long way toward fulfilling all of those goals. And at bottom, why do all this? Because pulmonary hypertension in children is a major problem, and it's a very rapidly changing problem. So classically, the blue section of the pie chart has been the majority of patients that were involved with pulmonary hypertension in childhood. And this involved idiopathic, hereditary, and patients who had congenital heart disease. But now there's a worldwide epidemic of group 3 disease associated with lung disease and hypoxia. And in all pediatric pulmonary hypertension, the major challenges are that the morbidities are severe, mortality is high, and we don't really know enough about very basic things. Like the question we asked, what's the best therapy to start kids on when they get a new diagnosis? We don't really even know what the best age-appropriate endpoints are for following these kids through. So don't worry if you didn't pick up your microscope glasses at the door. We're going to focus in on a blood vessel and on two major actors here, the endothelial cells and the smooth muscle cells. And the reason is that most therapy for pediatric pulmonary hypertension is focused on the relationship between these two cell types. Endothelial cells move the mediators, and smooth muscle cells do the business of badness, which we run into oftentimes at 3 o'clock in the morning in the ICU, where the pathway through blood vessels goes from open green light on your left to closed red light on the right, and the right heart and the heart in general are all of a sudden very unhappy, and we have a crisis. So we're going to focus on two of the pathways that are generated by the endothelium and directed at the smooth muscle cells that really are at the basis of our study: sildenafil and bosentan, the phosphodiesterase type 5 inhibitor pathway and the endothelin antagonist pathway. We were motivated in part by the AMBITION trial in adults, where combination initial therapy showed improvement in trajectory and in outcome. And so this is our study. Our hypothesis was that 2 would be better than 1. The molecular pathways would be twice as the number engaged. It's a phase 3 pragmatic randomized trial of these two groups, sildenafil alone versus bosentan plus sildenafil. And we did a lot of thinking about endpoints. We engaged experts in pulmonary hypertension around the world. And on one fateful Labor Day afternoon, we had a conference call. Of course, it wasn't holiday for most of our international colleagues. And we decided, despite many drawbacks, the WHO functional class at 12 months was the best primary endpoint. The secondary endpoints included things that we do all the time, but really don't know if they help us, like echoes and proBNPs. And very importantly, we wanted to focus on function. So we looked at exploratory endpoints, including activity science, actigraphy, quality of life scales, and some biomarker studies, which our Data and Safety Monitoring Board insisted be an optional part of our study. So we got going, as I mentioned, about 8 years ago. We started with the Trial Innovation Network, which is how we met BIOS. We applied to the FDA for an IND exemption, which was granted, and we got a UH3 grant after the UG3 startup year from the NHLBI. And we put together our team. Our PPHNet and BIOS colleagues formed the heart of the team. We continue to have tremendous support from the Trial Innovation Network at the National Center for Advancing Translational Sciences. Our DCC is the DCRI at Duke, and the NHLBI, of course, continued to sit at the table, as is the way with all UH3 mechanisms. We had challenges along the way, many changes in the field, including the fact that people don't like to cath babies anymore. So we had to open up our inclusion criteria to include echocardiography in kids under a year of age. The metrics are listed here. I won't go through all of them. And just as we began to launch our trial, the FDA approved sildenafil for use in kids, which meant that anyone who suspected pulmonary hypertension in their patients immediately prescribed sildenafil. So those treatment-naive, new diagnosis pulmonary hypertension patients were a lot harder to find. We addressed this in many ways, including a webinar by a world-renowned expert in the field to say, we don't know what's right. Help us figure out what's the best initial therapy. Out of the study have come many wonderful products, many of them initiated by investigators that you know well. Melanie Neese put together a terrific national and international panel of pediatric cardiologists and imaging people to make a panel of 19 different echocardiographic metrics for following the patients through the study. Alan Everett has produced a very compelling predictive modeling aspect of our project. And there are others here, including Mike Colasso, who you know well, who were very, very much involved in moving the study forward and contributing to the literature and to manuscripts which will soon be published. The ECHO protocol, I think, is a major contribution, as I mentioned. The actigraphy science, which was headed up in part by Kate Avita-Beal, who's at CHOP, one of the pulmonary hypertension specialists there, focuses us on specific ways to use the newest in actigraphy technology to follow infants, children, and adolescents with pulmonary hypertension and map their activity, because we're after functional endpoints. And the Trials Innovation Network contributed the MyCap app, which is an app for smartphones, which helps to keep the participants and their families in touch with the investigators, and is a means for medication diary and birthday greetings. So just a few perspectives. There we part on the clinical trials enterprise, things we learned. First of all, I think it's important to step back, and this is a recurrent theme, of course, in medicine and in these grand rounds, and say a word about diversity and trust. There's no question across biomedical endeavor that diversity is important. It helps us be better at everything that we're trying to do. And I think the last bullet point here is the most important. If we are going to have accurate and generalizable trial results, we've got to be studying a diverse population. But we have a problem, and the problem is that people don't trust us. We still suffer from the legacy of the Tuskegee trial and other issues that have marginalized very important parts of our population. And people say, research, bad word, don't want to get involved. We've got to build trust. This is a major challenge for all of us. Secondly, as the task force on pragmatic trials that the NIH has identified and has been true for us, there is a huge time gap between the inception of study ideas, for us going on 9 years now, and the collection of final data. And we've got to narrow that gap. The fields that we're studying just change too quickly. So thanks to the Trial Innovation Network, I think we are addressing many of these challenges, the two that I've just mentioned and many others. And I will end by simply thanking the wonderful people that I've had an opportunity to work with. This is our org chart, representative of the DCC pictured here, Eric Christensen and Lindsay Ezagire, who is going to be our next speaker at BIOS, who really helped us to get our study off the ground. And thank you very much.
Thank you. Thank you for the opportunity to speak with all of you today. You heard the Trial Innovation Network many times today throughout Dr. Romer's presentation. I'm just going to give you a quick overview of what the network does. If you're not familiar, we're designed to innovate and accelerate clinical trials. The Trial Innovation Network, as you can see, has 2 centers. We are one. The other one is at Vanderbilt. It also has a Recruitment Innovation Center that is also at Vanderbilt. We BIOS, as Dr. Hanley mentioned, in addition to all of the things that the network does, which is facilitating collaboration and optimizing trial feasibility and streamlining site selection, we also work on trial planning, grant organization, and trial operations. During Dr. Romer's consultation, we worked with him in trial planning and developing his idea. He mentioned that there's a lot of time in between. We really worked with him to try to fine-tune his ideas. And then we worked on his grant production, his grant preparation, where we embedded innovation tools to enhance his grant proposal. Once the grant was awarded, it was time for us to get to work, and we worked with him to plan his trial, we worked on protocol development, site training, to name a few. Most trials have challenges. Dr. Romer mentioned some of them. For us, for Kids Mod PA, one of the major challenges we encountered was enrollment. And in response, we developed and implemented operational innovations. And today I'll walk you through some of the ones that we had originally planned and some that we had to add based on these challenges. The first two that you see here, the centralized training platform for sites and the pocket card applications, were things that we embedded into his grant. The last two were as a response to the challenges that we were seeing. I'm going to be going over some of the tools and how we try to overcome them. The first one is that you can see is this is a training platform. When implementing multi-center trials, consistency in training, it's a big challenge. Not only are we coordinating sites across the country, but we're trying to get all of those sites and the staff trained in a systematic way. So without a structured approach, training can quickly become fragmented, leading to inconsistencies, and at times what we see is protocol deviations. As a coordinating center, the first thing that we do is we develop a well-structured training plan. And then we use a training platform, like the one that you see here. It serves as a single access point and is also multi-use. So we have all of the trainings in one place. We have study documents that you can see. We have recorded webinars, and we use it at the inception of the trial when we're trying to onboard sites. We also use it for retraining, and we use it to also disseminate anytime we have new materials to our sites. What you see here is a pocket card. For some of you, maybe in the old days, we used to do printed laminated cards that our staff would actually, I see some shaking hand, they would actually carry those laminated cards in their pocket. So what we did for this trial is we actually developed a short link so people can have quick access to the trial information in their phone. Everybody carries the phone, so they can access the inclusion/exclusion criteria, schedule of events. And the key thing is that they have it at the point of care when they're talking to our participants. So this not only is helpful for consistent training, but it also saves staff time. Everybody is very, very busy when they're in clinic. This is another view of our pocket card. This is what site staff can see if they access the pocket card via a tablet or a computer. What I want all of you to see is that everything that we created for Kids Mod PA, it's all in one place. That's what helps with training, consistency, and all of the sites know where to get the information quickly. Now I'm going to go over an unexpected challenge. Dr. Romer mentioned multiple times the issue that we were encountering, which is mistrust and lack of understanding. As you can imagine, this disease, it can be very overwhelming for families. So what you see here is a screenshot of a consent video that really takes the complex medical diagnosis and the research concepts and explains it in a clear, digestible language. These videos, both in Spanish and English, also take the information and present it to the participants and the families in a simple way where they explain the trial, they explain the benefits, and they explain the risks simply. For us, from a project management perspective, it also helps us standardize the information that is being shared with our participants. To tackle the same challenge, in addition to normal trial brochures that all of you probably see around the hospital, we developed these two tools. One is a patient journey, and the patient journey simply describes what activities are part of standard care versus what additional activities they are considered part of research. The screenshot on the right is a website. This is targeted for families. Not only are they able to get information about the trial in one place that is targeted for them, but it has also a way to contact us if they're interested in the trial. Dr. Romer mentioned some of our inclusions and exclusion criteria. One of them, a key, is for participants to be treatment naive. You heard about one of the drugs being released and being available to be able to be prescribed to our participants. Unfortunately, that's what that translated to is our participants being placed on treatment before SI teams could even offer the trial as an option. To overcome this challenge, we developed the referral letters. Dr. Romer became very, very popular on podcasts and lectures. And we also developed the provider flyer that you see on the left and the provider-specific website that you see on the right. All of these resources are designed to increase the provider's awareness in options. We then tackle a problem that is not unique to Kids ModPA, and that is having a low number of eligible participants at sites. Looking at our recruitment numbers, it was clear we needed to add new sites. For this challenge, we used a trial innovation expression of interest. And this is an outreach that goes out to the 64 CTSAs that I had on one of my earlier slides. This formal process helps identify sites and interested investigators across the country. The outreach can also include a protocol. It can also include a budget to assess feasibility of the trial. The process, more importantly, has an EHR cohort assessment. What happens is a phenotype is developed based on ICD codes that is sent to the sites. The sites then can use it to estimate the number of eligible participants at that particular site. Via this process, we were able to identify 16 sites that were interested. To objectively select among the 16 sites, we used a tool that we developed called Site Assessment Survey Instrument, also known as SASE. This tool collects quantitative and qualitative data to compare sites. It also identifies roadblocks to assess site feasibility. It also obtains PI's commitment to meet the enrollment goals and of having institutional resources and staffing to be able to do the trial. For us, it helps us avoid bias when we're selecting sites. A key feature of the SASE tool is a built-in report, and that's what you see on the right-hand side here. It consolidates sites assessments data, offering a structured way to evaluate sites' readiness. Another feature is a standardized scoring, and that's what you see on the numbers there, where responses are assigned a point value to calculate a readiness total site score. This ensures that a consistent evaluation of the sites. The report also identifies potential problems, and you see on the right that these are two examples of two sites. Both of them have potential problems, issues on the right, but you can see that one has a higher readiness score. These scores and the data that we collected helped us identify two sites that we wanted to make to identify, enroll, and actually activate for our trial. So as you can see throughout our presentations and throughout Dr. Romer's presentation, there's clinical sites, clinical trials have a lot of challenges, and I think for us is what sets them apart is what do we do to overcome those challenges. So that's the end of my presentation, and with that I would like to thank my team, and I'm going to hand it over to our next presenter. Thank you so much.
Wonderful. So thank you very much for coming today. I'm Gina Miller. I'm in maternal fetal medicine in the Center for Fetal Therapy.
I'm Meredith Atkinson from Peds Nephrology.
And so today we're going to share with you our experience working with BIOS in relationship to the RAF trial. Let's see. Okay. And the RAF trial essentially stands for Renal Anhydranous Fetal Therapy Trial. And the problem that we're tackling is fetal renal failure during fetal life. And the most severe form is bilateral renal agenesis. So with the complete lack of kidneys, it's obviously the most severe form of congenital anomalies of the kidney and urinary tract. And this impacts about 800 cases per year here in the United States. Now, maybe it can be identified in the first trimester by ultrasound, but because fetal urine is made by the placenta and transudate across the skin, we still have maintenance of amniotic fluid until that switches to fetal urine a little later in the second trimester. And other causes of fetal renal failure involve other abnormalities of the kidney and urinary tract that may be a little bit more obvious. So multicystic dysplastic kidneys, unilateral renal agenesis, or other forms of lower urinary tract obstruction. And we think about early onset fetal renal failure as a double lethal disease. So, and that's predominantly related to pulmonary hypoplasia. So first of all, we have the development of anhydramnios, which prevents the normal expansion of the fetal lungs. And so we have compression, and that leads to pulmonary hypoplasia. And then secondarily, the fetal renal failure is lethal without replacement therapy. And so the central question that we were trying to address in the RAFT trial is how well do amnio infusions that restore amniotic fluid during pregnancy prevent lethal pulmonary hypoplasia? And the source of this question started here at Johns Hopkins with a single case report reported in the literature that really created a lot of enthusiasm in the lay press. Around that time, there were a few other small case series that were reported. And so there was some limited observational data that replacing that amniotic fluid may mitigate pulmonary hypoplasia. What followed was a workshop with the NICHD and the NIDDK to propose a research agenda around this topic. And here at Johns Hopkins, we held an ethics summit with multiple stakeholders involved in this disease in order to suss out what were all the important factors that we need to consider. And with that, in conjunction with BIOS and the Trial Innovation Network, all of these factors form the basis of and the development of the RAFT trial. And so we had three specific aims. First of all, it's really important to remember that this was actually a maternal trial. We needed to first address safety for the maternal participant, because we know that a single amnio infusion is safe for the mother, but actually doing it multiple times over the course of the pregnancy, the risk profile for that was not known. So all of the adverse events that we assess are related to the maternal participant. Number two, first getting over that hump of initial survival, we really wanted to understand, well, how well did this allow children to survive without pulmonary hypoplasia so that the renal failure could be addressed with dialysis? So that was our second aim, was a surrogate to reaching treatment of your fetal renal failure. And third, we wanted to address the long-term efficacy. So how successful did patients reach discharge home? And the final measure was transplantation.
Thanks, Gina. So this is a schematic that shows you the RAFT trial study design, and the trial was done under the central IRB here at Johns Hopkins. And so there was a screening process. I'll highlight that there were multiple prenatal comprehensive consults required for enrollment in the trial. Then enrollment had to be before 26 weeks of gestation, serial infusions, delivery at a RAFT site, and then follow-up for some of the neonatal survival variables. And then the final outcome would be survival to kidney transplantation for any infants born as part of the study. So this map shows you the 13 recruiting sites for RAFT. So as Lindsay mentioned before, BIOS organized site assessment, selection, and initiation for the sites in RAFT, both for the initial 9 sites that were originally started. And then we actually added 4 additional sites during the course of the trial to try to complete our enrollment on schedule. So the initial goal was to recruit 140 total maternal fetal pairs, 70 in the intervention arm, 35 with bilateral renal agenesis, and then 35 with other causes of renal failure. Our recruitment changed a little bit in July of 2022 after an interim analysis and also a convening of our DSMB. And at that point, the DSMB recommended stopping recruitment in the agenesis arm of the trial due to efficacy in demonstrating the effectiveness of the primary outcome and also concern for a high burden of morbidity in surviving neonates. And I can't emphasize enough how useful and helpful the BIOS DSMB team was with keeping the meetings organized, reports, following up on recommendations. And so the one arm of the trial finished in July of 2022. We actually just finished enrollment in the trial overall at the end of February, so about a month ago. And these numbers are the total screening and enrollment for the trial overall. We had 189 participants screened at a RAF center. 134 of them did not either met inclusion or met exclusion criteria. The most common reasons for that were having other fetal anomalies aside from a renal anomaly, inability to start amnio infusions by 26 weeks, or participants electing to undergo pregnancy termination after the comprehensive prenatal consult process. The results for just the bilateral renal agenesis arm were published in December of 2023, and I'm sharing some of those here quickly. We were excited to get this in a fairly high impact journal. BIOS does have a medical writer who assists in helping to write things up. So in terms of the primary safety and feasibility assessment, there were no serious or unexpected adverse events beyond what you would expect for repeated infusion. So prevalence of PPROM, membrane separation, and vaginal bleeding are here. And then in terms of the efficacy, 82% of the cohort survived to the primary efficacy measure, survival to greater than or equal to 14 days. Not surprisingly, some of the factors associated with survival included gestational age greater than 32 weeks at delivery, a longer time from the first amnio infusion to PPROM, and a higher birth weight. And then the table on the right, you're not meant to read that, but just to illustrate that the publication did include detailed reporting of the comorbidities noted in some of the neonatal survivors. In terms of the longer term outcomes, including survival to discharge home, this was reduced compared to the initial survival. So 82% survived to the primary outcome, but 35% of live-born infants subsequently survived to discharge home at a median age of about 24 weeks. And then the publication for the initial closed arm included description of comorbidities, one of which was stroke. And so Don Lammert and Lisa Sun here in neurology have done a lot of work in characterizing these infantile and neonatal stroke outcomes as well. And the other thing that the trial includes is serial quality of life assessment for families whose infants did survive to discharge home from the hospital. These are collected every 3 months. I'm sharing a little first look at the data that we presented last year at PAS in Toronto, demonstrating families' reports of anxiety and worry about their infants after participation in RAFT, and there are more details, but in the interest of time, I will move on to say that at this point, RAF and the TIN are helping us in the planning phase for a proposed RAF2. And so some of the things that they have already helped with are identifying a potential funding mechanism, this UG3-UH3 that Dr. Romer's study has used. This is designed for multi-site trials, development of specific aims, sample size calculations. This mechanism requires a multi-step application process. So a letter of inquiry, then a concept proposal, and then an application if you're invited. So that's what we've been supported in doing so far. And there's some preliminary aims in the box there. And I'll just finish by acknowledging the funding for RAFT, which is from NICHD, obviously the TIN and BIOS, a list of most of the participants at sites. And I have to acknowledge Dr. Eric Jellin, who is the pediatric surgeon here, who really championed this trial and without whom it would not have happened. And so his loss is felt every day. And I'll just finish with some pictures of some patients with their permission, and we'll move on to the next speaker, who's Nolene.
Thank you. Good afternoon. So I wanted to focus a little bit more on what BIOS did to help support the RAFT trial. Generally, when writing and submitting a grant, that represents months and months of work, and we think the work is, we've done everything and we submit it. But once we get funding, then where do you start? That's where the work really begins. So at BIOS, we've developed several programs which will help investigators get started along the right pathway. And you've heard about a couple of these tools already. The logical place to start when you have your grant is with selecting of sites. And the mechanism that we've developed at BIOS, you've heard about earlier, is called the SASE. This is a tool that Dr. Romer used and sent out to all of their ICTRs to identify sites. You can also use it in studies where PIs have already identified some of the sites. It focuses on 3 areas. It is a pre-study survey that focuses the PI and the study team and identifies key contacts for site startup and study contact. It provides the BIOS Coordinating Center with information on specific areas at each site that may require additional focus during the site startup or throughout the conduct of the trial. So, as we said, during the RAF trial development, the PI began working with the North American Fetal Therapy Network, NAFNet, for study support and for identifying potential sites. In a study such as RAFT, where this is a rare condition and there aren't many centers capable of doing the serial amnioinfusions, it's really important to focus on finding sites that are going to be able to meet the needs of the study and follow the patients clinically and provide necessary clinical treatment. So it was a natural partnership for BIOS and the RAFT trial and NAFNet because the requirements of NAFNet membership and its primary mission align with RAFT's resource requirements. So with the assistance of NAFNet and BIOS was able to identify potential sites who would be interested in participating in the RAFT trial. We sent the SASE out to all of those candidate sites, and let's see how the SASE was useful. You saw a little bit of this graphic earlier. This is a report that we get, and this is a condensed version, where the questions are ranked and the sites are scored by their readiness potential to achieve the objectives of the trial. Do they have the resource and infrastructure to complete this? Do they have the staffing? Also included in the SASE report are potential issues identified from the site responses. Listed here are recurring and frequent issues across sites, as well as a few specific sites. I've narrowed it down to make it a little more readable. The data platform that was being used for RAF was REDCap, and we were also using that not only for data entry, but for the housing of all of the regulatory documents and the training platform. A number of our sites expressed concern that they were not familiar with using an electronic data capture system for housing those kinds of documents. So that was one area we knew we were going to have to focus on in site startup. All of the sites were also new or had limited experience with remote data monitoring. And there were a number of issues related to uploading source documents or reports that might have PHI in them. We needed to work with the sites to overcome a lot of those issues. All of that information helped our team of site navigators at the coordinating center as we started to focus on site startup and conduct of the trial. So after we've used the SASE a number of times, you've heard that Dr. Romer used it, we used it in RAF, and there are a number of other trials that have used it. We wanted to get an idea of how the sites perceived the SASE. Was this a useful instrument? So we asked several questions, and there I'm going to show 2 key ones that said, in general, did you find the survey collected useful information about your site? And you can see that the sites overwhelmingly thought that it did. This helped us to focus on getting sites started up. Okay, the other one was, did the sites feel that the questions we asked were helpful to them in identifying what it takes to make a trial successful? Takeaway from the slide that I hopefully will be showing you in a moment is that routinely, the sites that were determined to be ready and have the infrastructure using the SASE performed better in terms of getting sites started up and enrolling their first patient. It took about half the time, or a little more than 6 months. There we are. Thank you. The column on the right took about half the time to the first enrollment that it took for the sites who said, yeah, we're interested, but we're not really all that organized, but we need your help. So we find the SASE is very useful in terms of getting studies up and running. And when you have a trial that has a rare or a condition, enrolling sooner and having a longer enrollment period is going to be one of the key things for getting your enrollment. So going back to RAFT, we had sent the SASE out to 8 potential sites that had been identified by NAFNet and BIOS. And here are the sites that we decided to pursue to get started up on as our initial cohort of sites. I showed you the results with potential sites and ranked them according to readiness. And 6 out of the 8 were deemed high readiness sites or would be able to get things up in a timely manner. And there were 2 that needed a little extra time to get started. So we moved forward with onboarding all 8 sites. And we started using the next innovation from BIOS, which is called the Accelerated Startup. We have a dedicated team at BIOS to help start sites up, to help navigate them through the startup process. And it focuses on 3 key areas: all of the regulatory documents and training that needs to be acquired, the IRB process of getting the initial study approved, and then adding all of the sites to the study. RAFT was one of the first studies to use the central IRB model with Hopkins as the main IRB. So we had to work out all the mechanisms of adding all the other sites to the study. And we also assist with contracting. This is a 3-prong approach that we use over a structured 12-week period. And BIOS has a team of what we call site navigators who pair with each of the sites and walk them through this process. And each week there's a new milestone or a goal to try and get things done in a more timely manner. Once the trial is underway and the sites are up and running, BIOS, with those site navigators, continues to support the trial in a number of key areas. We have a team that works with the IRB so that they handle all of the protocol amendments, any continuing renewals, protocol deviations that need to be reported in a timely manner. We also, as Meredith indicated, have a dedicated data safety monitoring board team that helps coordinate with setting up the meetings, generating the reports, conducting the meetings. But in addition to that, behind the scenes, we have a data management team that helps us with biweekly reports. These are reports that are generated regarding enrollment, safety, monitoring of the data for completeness and accuracy. These usually go on behind the scenes, and for RAFT, we get our reports monthly. Some get them biweekly, depending upon the enrollment, how quickly we want to see how things are changing in areas that we may need to focus on. So you saw this on one of Dr. Atkinson's slides as well. Early on, in about the 3rd year of the grant, we identified that enrollment wasn't quite as robust as we had hoped it would be. And we were trying to identify ways to mitigate this and to help us increase our enrollment and complete the study on time. So it was at that time that we decided we had the budget and the capability for adding some new sites. So we went back to our SASE and back to NAFNet. And for members of NAFNet who had expressed in the intervening couple of years that they were interested in being part of RAFT, we developed a new list of potential sites, sent the SASE out, and when those results came back, we looked at the rankings and looked at those. Because this was mid-study, we were really anxious to get the people who were most ready and capable of meeting the study's objective. So we were able to identify 4 candidate sites, which we then moved on to the Accelerated Startup, the 12-week program to get these new sites onboarded. We were able to do that in a fairly quick manner, and that allowed us to increase our consortium to 13 sites, which is where we ended up with when we finished our enrollment. So this is also a great way for us to extend our relationships with the sites. And as Dr. Atkinson mentioned, we are in the process of planning RAFT 2, and we have all of these partners that we've worked with and know are capable of meeting our study goals in a timely manner. So we have a good starting place for RAFT 2. Thank you.
Thank you very much, Nolene, and thank you to all the speakers. That was wonderful. We have a brief panel discussion to take questions from you about the trials. I think everybody should come and sit up front. I'll start out with Meredith and Gina and Nolene. What was the single biggest unexpected barrier that you had to overcome?
I guess I think it was the DSMB recommending that the child stop early. I think that was definitely a barrier. And it was great to have an experienced trial team helping us do that and helping us sort of manage our DSMB. Very small clinical trials before, but nothing where the DSMB was sort of a huge part of the conduct of the trial. So I think navigating the process and then how to proceed in this.
It was difficult with sort of contradictory messages from the DSMB that you both had a sign of efficacy, but they somehow weren't convinced and didn't want you to go on with your planned third aim, which was the long-term goal here. But I thought you answered it well by putting your data out into the general public and letting the general public decide.
Yeah, it's a little unusual to publish a single arm of the trial that's not complete yet. And thank you for bringing that up because we talked with the consortium, knowing that this is a therapy that would probably be offered more widely as a result of the trial. We felt like it was really important that if the arm was done, that we get the data out into the literature so that people who were thinking about undergoing this intervention and being counseled about it would have available published data to use to inform their decision.
Which was the goal of the ethics paper you had, your group had engineered before the trial ever started.
With the way that you work to manage some of the obvious ethical questions when this trial would start. And I remember conversations with Eric and I think with you, Meredith, about this. And I wondered how that work affected the DSMB's decision. Do you think that the DSMB was reassured by all of that work or ignored that work, or did it have an impact?
Dan,
Yeah, sure. I think that's important. Thank you for reminding me. So for the people who are on the video, the question is that a large amount of legwork was done on the risks versus benefit, on the beneficence of this study, and a paper was written. And the question asks the team, was that helpful in dealing with the DSMB and the issues that they brought up?
That work was certainly helpful in framing how we thought about the trial. It allowed us to reflect on the things that we anticipated that would become issues, and that framework was established within my paper. One of the big lessons, I think, from my perspective, was thinking about diversity on the DSMB, and that having also equal representation of stakeholders across the spectrum of disease would also perhaps have.
Right. As the lawyer for the two PIs and the team, I'll give you a more direct answer. We offered the DSMB to consult with the group that had dealt with these issues in a much more detailed manner. And the DSMB declined that opportunity, which was disappointing. But at the same time, I think the team used the plan that was set out by the ethics paper to provide data as opposed to opinion. It's clear that many people across the country are interested in this intervention at this time. Other questions? Same question for you, Lou and Lindsay. Your biggest unexpected challenge?
So, for me, I guess, there were two that were unexpected. The first was that although we had written a grant together, we had a fairly good esprit de corps, there seemed to be quite a difference in engaging the business of getting the trial going in terms of activation energy between the CCC and the BCC, and communicating the importance of the vision, time sensitivity of the trial was a challenge. And the second, for me, I guess the thing that hit me the most was that we've been through a grant proposal that had been reviewed, and we're awarded a grant, we were ready to go. And then the DSMB seemed to be a whole second review of our entire trial, from the very basic premises that we were questioning to our assumptions that things we were doing were safe and state of the art. They seemed to want to take us down. That was jarring and interesting, and helped us to be the improvisational professionals that we are.
Right. Okay, so Karen and Nicole, do you want to speak to the importance of collaborative environment and teamwork, which was one of Lou's issues?
One of the issues that not only we have maybe encountered a lot of problems where there needs to be, one of the things that we had to really work on was to work with our BCC, work with even our funders. I think that can be a really mentioned Dan, you asked what challenge that was exciting. Honestly, as a childless and as a project manager, and then have help every decision you can think of throughout running a clinical trial. For me, having to work with and our funders in making it is very challenging. Having to explain our rationale of why we're doing things and having to go back to the drawing board was very challenging, along with ensuring that we were working with our partners so having building this consortium and working together was one of the biggest challenges that I think I have ever overcome, and I had to overcome this, and we did it together. I think it resonates with Dr. Romer's personality. He was the champion of bringing all of us together and helping, have difficult conversations sometimes. So,
I'll just add to that one of the value adds for CTCC doesn't get commercial. We are celebrating our 25th year anniversary, and those 25 years really brings a lot of infrastructure and standardization that the PIs here today, others have benefited from, so that our standard operating procedures and our workflows around consortium development, and not just the sites, but the other stakeholders and the other coordinating centers and the vendors, every single person involved, which is quite complex in the development center. We already have a lot of that in place to then be able to focus on what makes it specific to this trial and being able to adapt quickly so that we can accomplish what we need to on time.
Right. And that's the history question, which you so correctly went to. One of the thoughts we have is at the beginning of a trial, you develop a data safety monitoring plan. And that's something that this broader group, where Lou pointed out there wasn't as much cohesion as there could have been, all had to sign off on. And I think we've learned that we need to do a better job of using that as a template when you work across institutions and across sponsors. And I think for our next set of trials in pediatrics, where there are vulnerable populations, we want to build in thoughtful use of people like the Ethics Committee and the SIRB. And I think that may help us with some of these issues. I think the other part of the issue is how do you respect time? And Lou brought this up in the beginning of his presentation, that it's taken 9 years to get to where he is. And sometimes we can over-examine issues and underperform on actually doing the trial. And I think that's probably the second area where better cohesion needs to be built.
Yeah, I also I know we're out of time, but I sit on both the IRB as an ethics member, and also I sit on several DSMBs, and I really struggle to keep a DSMB focused on its tasks, because most DSMB members want to go back and redo the IRB work. And I don't really know how to convince people that those are two separate functions. If you guys could help with that work, it's an important question, and it creates so much havoc when the DSMB wants to redo the IRB work. I have never been successful in convincing a DSMB not to do that. And I've tried lots of different ways, but it's just there's something about the nature of the work. They're both really, really important, but the DSMB has a very different charter. And I don't know, I think we all need to do some better work in helping DSMB members feel confident about the IRB work and confident about their role in the DSMB. It's a separate thing. Both your stories were incredibly talented.
If I could chime in out of turn, I would say that.
But before you do,
Yes.
so the question for everybody who can't hear it, the comment is sometimes DSMBs try to redo the IRB work. I'd add to it, they often try to redo the reviewer's work, which, okay, go ahead, Lou.
My comment was just that I don't know how much investigator initiated comment for DSMBs there is in the literature, but I suspect there's not enough and it's not focused enough. And perhaps that could have ultimately an impact on how DSMBs do their work. Because if it's counterproductive, I'm not sure who it's helping.
Right. I'll give you one more chance, Karen Lane. Do you want to tell us about stay in your lane in trials? You got people to stay in their lane to do a 15-month COVID trial that ended up with a practice change in paper. How important is that for people with different charters and different portfolios to stay in their lane and assume that the other folks are going to do their jobs correctly?
Well, I think it's important in team science that you at the beginning of a trial during the planning stage, that you recognize that there are teams, and in those teams, they each have their specialty. And it not only is in effect and a need during the trial, but it is also very, very important from the very beginning, at the time of the award, when you're doing your planning, that teams develop quickly and continue throughout the life cycle of the trial.
Right. And I think there's that element that needs to be built into the expectations. And it has been built in some trials successfully. Perhaps the burden of concern with the complexity of parents, a child, an investigative team, and sponsors is heavy in pediatrics. But at the same time, I think there are lessons to be learned. In adult trials, some investigators have pointed out to DSMBs that the IRB has already evaluated that point. that the reviewers have evaluated that point. And a good word for everybody who gets anxious is equipoise. We don't know the answer, and it's been determined, which was the problem that the RAFT trial had. It's been determined that there's equipoise and that there's beneficence on both sides of the question. And reminding people of that's one way to perhaps help. Thank you for your good questions. Thank everybody in the panel. And the audience. We appreciate you staying on.
Thanks, Dan. It was great.
Good job.
It was very, very impressive. And I know just part of a series of grants.
Yeah.
Congratulations on
Good. Being
all your
25
work.
years old.
On being 25 years old.
There you go.
Carrying your brain trial into all this next generation of investigators.